Brad, just wait. Just wait. Sorry. Nice shot. You got a minute just to do a quick talking with docs?
Kind of busy, Paul. We're at a hospital golf tournament today.
It's just gonna take a minute.
Okay.
Welcome to another episode of Talking with Docs. I'm Dr. Paul Zalzo.
And I'm Dr. Brad Wiening.
So today we thought it'd be a good opportunity to discuss golfer's elbow.
So we're out here trying to develop golfer's elbow. That's the kind of talking docs we are.
And I know most of our viewers are thinking, thank God they're not doing swimmer's ear.
A host of other things, I'm sure.
Yeah, or gamekeeper's thumb.
Gamekeeper's
Brad,
thumb.
let go of the chicken.
So today we're going to talk about medial epicondylitis or golfer's elbow.
It's going to be tough to do it out here on the course, so we're just going to hop back into our studio and we'll take it from there. Okay, so back in our natural habitat here.
I'm sure the viewers are keen to know how we fared at the hospital golf tournament.
It was a good day. We had fun.
We did have fun. We tied for third. We podiumed.
You know.
We had a very weak back nine.
It's okay.
Yeah.
The radiologists won.
Hey, yeah, don't even get me started. They're a good group of players. Good players.
They have more time to practice.
I wasn't going to go there.
No?
No, you just did. Okay, so what are we talking about?
Golfer's elbow.
And interestingly, we were joking about getting it, but I've actually had it for now 7 months.
And did you get it from golfing?
No, I don't golf in February. Thankfully, in Canada, most people get a break from golf from November to April because of our tundra and the winter here. But no, I think I might have got it from work, from the vibration of the saw in the operating room, I think.
Really?
Yeah.
Is that one of the causes? Okay, well, let's talk about what is it? What is golfer's elbow? What's the medical term for it?
So the medical term is medial epicondylitis. And we've taught you in the past that itis means inflammation.
That's all it is. And medial, so the inside, and your epicondyle is that little bump on the inside of your elbow. That little guy can get pretty inflamed.
Yeah, which is part of your distal humerus bone. And yeah, it certainly can get inflamed. So, but is it the bone that gets inflamed, Paul?
Well, what happens is right on that little bone, a lot of muscles convalesce into a tendon that attaches onto that little bone. And all the muscles that flex your wrist all come down onto that bone. So that's a lot of force, a lot of tensile force being applied to that bone.
Right.
And so the junction where the muscle meets the bone gets inflamed.
Right, so they talk about your common flexor mass. Like Paul said, there's 5 muscles that come, one common tendon, and that piece gets pulled and pulled with repetitive either work or golf, or some people say overhand serving in tennis. And so it's just not only just flexion, but pronation is only you turn it over.
Yeah, can we lump it together with tennis elbow?
So you could, but I think it would be wrong.
Lateral epicondylitis, so that's on the outside and that's coming from the backhand in tennis.
Yeah.
The extensor muscles that extend your wrist all insert on that little bump on the outside of your elbow, and that can get inflamed with a lot of repetitive backhand. But you don't have to play golf or tennis to get golfer's elbow or tennis elbow.
No, often work related from repetitive stress. Yeah. And interestingly, lateral epicondylitis is actually 5 to 10 times more common than medial epicondylitis.
Is that right?
Yes.
I had medial when I was younger.
Yes.
I think I got it at the gym when I was doing a lot of tricep pull downs.
Working on your tris?
You know.
Nice, I like it.
For the beach.
I would say the other group that is vulnerable to getting medial epicondylitis are the throwers. Right. We want to make sure that we talk about them, particularly baseball players and pitchers. Yep. So not only can that tendon become irritated, but the little ligament that supports that medial side can become a problem.
So we're petitioning to change the name to anybody's elbow instead of golfer's elbow.
The golfers really are the least important group here.
Anybody's elbow.
Okay, so we know what it's called.
Anybody's elbow.
We know who gets it. Mm-hmm. So what did these people present with?
Well, pain. Pain is probably the most common cause. And it just comes in, it hurts right here. It's really sore when I do stuff that does involve flexing the wrist or supination or pronation, depending on which side. And it's often activity related.
For sure. Yeah, usually not night pain or rest pain, but with those flexion type activities or resisted activity and either on the bone or even just a little bit distal to it or beyond it. For sure. So you got pain.
That's basically the history.
Yep.
And on exam, what do we find when we do a
physical exam? When you push, it hurts where they said it's sore, and then you can do some special tests where you resist flexion, and that can aggravate the pain. Those are probably the 2 most important tests.
Right. So it's a straightforward history, pretty straightforward physical examination.
Yep.
And then I always start with an X-ray.
Yes.
We always start with an X-ray, just see what's going on, make sure we're not missing any other bone lesion.
Are you going to see it on X-ray?
you most likely will not see anything on X-ray.
Right. Sometimes they said with repetitive stress, you can find a little bit of calcification of the ligament or the tendon insertion, but yeah, usually it's going to be normal, and you're going to be like, yeah, we thought it was going to be normal.
Yeah.
What about other tests, special tests?
Other tests that we can do often to look at the soft tissues, we do ultrasounds to look at the tendon, look for inflammation or tendinosis or tendinitis or even a tear or something like that. And ultimately, even better to look at soft tissues, better than ultrasound.
Gold standard?
MRI.
Yeah, and I think it's to not only identify the exact area and problem within your epicondylitis, but to make sure that that's what you have in case you have a bit of a more odd or atypical presentation.
There's something wrong in the elbow, maybe some problems with the cartilage in the elbow or something like that. So history, physical examination, special tests.
Okay.
Boom, here's your diagnosis.
People are here not for those first three. They're here for number 4.
Yeah. Often they don't say, thanks for the diagnosis, doc.
That's right.
It's been a pleasure.
I'll be on my way here.
No, rarely does that happen.
They want to know what the treatment is. So first of all, is this a very successfully treated problem?
Case in point right here, it can take a long time to get better.
Yeah, for sure. So A, don't despair, and B, kind of bunk in for the long haul, because it can be brutal.
Yeah. Yeah, I mean, we don't want to scare you away, but it will get better. It most likely will get better, but it's going to take some time.
Okay.
So, and that's probably the first, treatment is time. You have to give it time for your body to heal it.
Right.
Which means rest, and if you can, avoiding that repetitive motion that you're doing that's causing it.
Right, so easier to say to a golfer than, say, a carpenter or a jackhammer operator or whatever. Yeah, so I would totally agree. Rest and modifying your activity.
Yeah, so that's the key, modify. Like, okay, so when I'm at work, this is what it happens. So
can I play 9 holes then? Is that what you're saying?
Yeah, it's like don't work, don't do 9, whatever. But modify what you're doing such that you give your body a chance to rest it.
Okay. Number 2.
Activity modification. So
yeah, I would say ice, and it actually certainly anecdotally for me, I got symptomatic relief. Sometimes you could actually see days where it looked a little more swollen, and a therapist that I saw that we'll talk about after did say that there was some visible swelling there. So ice always makes sense for almost every orthopedic injury. So
yeah, it helps with the swelling and inflammation. So ice for sure.
Okay.
An anti-inflammatory.
Yes.
Right? Be it topical or oral. Some people can't tolerate oral anti-inflammatories. Check out one of our other videos where we talk about some of the issues to your kidney, your blood pressure with anti-inflammatories with oral ones. So check with your family doctor or primary care physician if you can take anti-inflammatories. But topical anti-inflammatories are often very safe and can be very useful too. And
you can really localize where your problem is, which is nice, and it's relatively superficial, so they're particularly appropriate. Would totally agree. What about, can people take Tylenol for this?
Sure, you can take acetaminophen as an analgesic.
Probably going to help more with the pain than the problem, though. Would you say that?
Yeah, I would agree.
Okay, so that's 3. My number 4 would probably be some type of brace. So the thought is when that flexor mass keeps being pulled on over and over and over, if you get a brace where a tight band is placed distal to the problem, it can change the area that rubs the most. Almost like a pulley kind of system where you can move that friction point distal to the problem. So
they have those bands. You've seen those bands. Some people have worn.
Sure. I wore one. Sometimes it feels like it helps, and sometimes it doesn't.
All right, and physiotherapy or physical therapy, as you say.
Yes.
Often, we use that for the vast majority of our orthopedic conditions as well. We heavily rely on the help of our colleagues, our physiotherapists, our physical therapists to help with that kind of stuff.
Yeah, critical. So passive stretching exercises, eccentric strengthening, where they'll teach you how to actually let your wrist go down so that it's actually doing the opposite of a flexion movement with a weight, so that I actually work on strengthening it. And then they can do some local treatments like scraping, where they have almost like this little thing that you scrape old dishes with to scrape the inflammation away. Sometimes things like dry needling and or acupuncture, more invasive procedures, have some evidence. Therapeutic ultrasound, actually, there's a little bit of scientific support for.
Yeah.
What about shockwave?
Shockwave therapy, that was, I remember seeing that a few years back. That was very popular for treatment of this kind of stuff, or Achilles tendonitis, things like that. I haven't seen any really convincing evidence that yes, it works, it's extremely successful, but it is still, I think, being done.
Totally agree. There's almost no evidence to formally support it. So yeah, maybe worth a try. It's relatively safe, but don't hang all your kind of weight there. Okay, what about next level invasive stuff?
So some fancy stuff.
Before surgery, what about injections?
That's obviously the next step in level of invasiveness of treatment. As you know, we always start with the least invasive and gradually move to more and more invasive treatments, injections. And really, I think there's at least two main types of injection you can think about. One,
I would agree.
Corticosteroid, right?
Yeah.
Corticosteroids are very powerful anti-inflammatories, and they can be injected right into the vicinity to help take down the inflammation.
Right, and I think they play a really significant role in the acute setting. However, there's lots of evidence to show that repetitive injections in the same spot can lead to tendon problems. So the literature clearly states avoid the repetitive injections, maybe one or two. You'd have to discuss that with your treating physician. But yeah, beyond one or two, I think you probably have to look at other choices.
Right, agree.
Are there other good choices? Okay, so that we're orthopedic surgeons, so what's the deal with surgery for this kind of stuff?
Well, before that, there's still one more type of injection.
Oh, right, yes.
The PRP.
Yes, kind of exciting actually, a little bit.
Kind of the more recent, newer ones, platelet-rich plasma injections. You've probably seen that kind of stuff online where a sample of the patient's blood is taken, it's spun down, and the platelet-rich portion is re-injected into the area. How's the evidence on that? It's
a little better than PRP is for arthritis, and it makes sense, I think, because soft tissues have more inherent ability to heal than our articular cartilage does. So I think it has like a low-grade recommendation at this point.
Okay. It's a little pricey too.
It is pricey.
Because it's a procedure, it takes time.
Sometimes you need multiple injections.
Yeah, okay, so there you go. We've gone non-invasive, a little bit invasive with some injections. Surgery, the ultimate invasiveness.
Yes, and a little bit unpredictable in this setting. So, for example, if for an advanced arthritic knee, we know that a knee replacement is a successful operation with a relatively predictable outcome. For this area, it really depends a lot on the specific location of the problem. If you had an associated tear, whether we could do an operation where the incision is made and you go in and you clean up some of the roughened area, or you potentially sew the torn part. So it is a little more unpredictable.
Okay. It's a treatment option.
Yes.
It's accepted treatment option. It is done. However, the outcome is not very predictable.
I would definitely want someone too that has a special interest in the elbow, I think, to be there, because orthopedic surgeons, I think it's an uncommon procedure. So you want someone that has this as a routine part of their practice, I would probably say.
Find that elbow person out there.
Right.
If you're gonna go down that road, you don't want to be going to someone who just does one or two of these procedures and every year,
especially hey, it's baseball time, right? We're in a wild card race up here in Toronto. The Jays were able to sneak one out against the Rays last night, and you hear about all these pitchers that have things like Tommy John surgery, which is in the same area. It's just it's more the ligament than the tendon. So you want to have someone who's an expert.
Yeah, I'd agree.
All right.
I got a touch of the lateral epicondylitis.
From tennis?
I never played tennis, but I just get it. And one thing that surprised me was how sensitive it is.
Oh,
too. If
you bang it.
Inside, if you've got medial epicondylitis or lateral epicondylitis, and it just grazes against something, it hurts quite a bit.
Yeah, it hurts a lot. I would totally agree with you.
Yeah, we can empathize.
Yes. So that's a great summary. The diagnosis, the examinations, the treatment options, as well as the natural history and kind of what to expect. So, hey, if you like this video, please like it, subscribe to our channel.
And remember, you are in charge of your own health.
We'll see you next time.